Hello all, I'm Dr. Shweta Santalia, Course Director at MRCOG, and today I'm very glad to discuss the topic of one of the new talk, a focus on progesterone in HRT. Now, most of the time I get the query that which are the talks important for the exam. Yes, talks do play an important role in exam, but at the same time, guideline are the one which always play a major role in the exam. In terms of talk, you should focus on last 2 years of talk, like for July 2025 exam. You should focus on 2023 and 2024 talks. So you don't have to go through every topic. You have to select and you have to prioritize which are the exam favorite topics, and you have to then read off the recent update about that topic. So not all the topic you have to read. You have to be selective. At the same time, you have to make a small summary out of it and try to remember that. You can't remember each and everything from the talk because it's an article. Ultimately, it's a journal and an article where there will be a lot of study, a lot of numbers will be there which you don't have to memorize. So it's important that you read the talk and concise it in a meaningful manner. Otherwise, you will get lost with so many talks available. And if you focus on that, you lose your focus on guideline, which is not advisable. So that's about your strategy, how to read the talk and which talks to prioritize for your exam. So I'm very glad we are discussing this important topic of HRT today. HRT is always RCOG favorite exam topic because HRT is quite commonly used here. And HRT as well as unscheduled bleeding on HRT is always uh, take priority in exam question. So HRT, because it is not used in all the countries so rampantly, then some of us might not be aware of different preparations available, what are the different content, different routes, different type of progesterone and estrogen in HRT. So this will be a helpful session for you to solve the questions in exam. I'm very excited to announce that AIM-MRCOG standard course of 5 months is starting soon, and it includes the free crash course. Uh, the fee and the contact detail are here. The course feature are here. It also includes the live crash course where we can discuss the question and the tips and tricks of EMQ solving, because that is what most challenging in the exam. It also have the group discount, student discount. If anybody is struggling with the fee structure, they can always contact. And if you want to start your study in a strategic manner with a time-bound period of this intense module, then this is going to be very beneficial with your busy schedule. So let's start. What are the key points? Key points about progesterone is that any women receiving the HRT, they are receiving the HRT for the benefit of estrogen. So HRT is what? Estrogen plus progesterone. Why we are giving estrogen? To alleviate the symptoms of menopause like vasomotor symptoms, um, uh, cardiovascular health, to keep the cardiovascular health better, for bone health, and as well as a slight effect on the dementia. So estrogen has many beneficial effects. That's why the women choose to take it to avoid all these symptoms. But at the same time, you have to give them progesterone to prevent the endometrial hyperplasia and carcinoma. So for endometrial protection, you have to give progesterone. Unless the woman has removed the uterus by hysterectomy, where you don't have to give progesterone because there's no endometrium to protect. Now, the exception to this is endometriosis, where you will, despite removing the uterus, you will be giving both estrogen plus progesterone. Or if subtotal hysterectomy, where some endometrium is left in the subtotal hysterectomy, then you want to protect that, so you will give progesterone. So these both are the exam question, recall questions. So be very, very clear about HRT, what preparation you are going to give, when you will give only estrogen, when you will give combination. So you give the combination, you give the progesterone to protect the endometrium from overgrowing and developing into cancer. Now, choice of HRT, there is 2015 talk about choice of HRT, which is very important. There's 2019 talk about unscheduled bleeding on HRT, which is very, very important. So we have already discussed that in session. Today we are discussing this new talk of 2023, where they have focused on type of progesterone and what are the new emerging evidence about that. So when we use progesterone, it has variety of types as well as the doses and the routes. So this is what we are going to discuss. Progesterone do have some side effect which might be mild but which can be debilitating for some of the women, and it might affect the compliance. So it's important that we always explore women preferences and what will be the acceptable side effect for them, and accordingly we give them the right progesterone. When we give them combined HRT, the downside of it is that the progesterone component of HRT can lead to a small increase in absolute risk of breast cancer. But again, in talk it is highlighted that though the risk of breast cancer slightly increase, but it's not that significant in terms of number, and particularly if we compare it to the modifiable risk factor like obesity, alcohol intake, and if we modify that, then it further decreases. And the other important aspect to consider is it is all dose duration dependent, and once you stop the HRT, the effect get completely nullified. So which is important in counseling the women, that there is a small risk of breast cancer, but benefit outweigh the risk because it will alleviate your symptoms of menopause and improve your quality of life, and as well as once you stop it, the effect will completely go away. We all know that role of progesterone in endometrial protection is well established, but still there is further work required to evaluate the long-term impact, particularly on the cardiovascular diseases and dementia. So if we talk about types of progestogens means all type of progesterone, the natural as well as synthetic. So progestogen means all the hormones who have the progesterone receptor activity. What are the natural hormone? What is secreted in our body in corpus in the second half of cycle in secretory phase through the corpus luteum is natural progesterone, which is highly selective for the receptor. Now, what is progestin? These are synthetic progesterone-like steroid hormone. Similar activity to endogenous progesterone, but at the same time, they also act on other receptors, which are steroid receptor like androgen receptor, glucocorticoid, mineralocorticoid receptor. So that's why they will have some side effect of testosterone like acne, hirsutism, and some side effect of glucocorticoid, mineralocorticoid activity leading to fluid retention. So these are the main two side effects with the progesterone. One is its effect on the mood, second is the androgenic side effect, and third is the fluid retention. This is all because of the overlap of the activity due to its steroid hormone nature and acting on not selectively on progesterone receptor but also on the other receptor. So synthetic progestins definitely is beneficial, but at the same time it will have some extra side effects. And if we talk about micronized progesterone, that is more towards the natural progesterone. So it has more safety profile with less side effect. So what are the synthetic progestogens? Again, synthetic progestogens can be of two types. One is structurally related to progesterone and one is related to testosterone. So if it is related to progesterone, definitely it will have lesser testosterone side effect like medroxyprogesterone acetate, cyproterone acetate, and dihydrogesterone. If it is structurally related to testosterone, it will have more acne, hirsutism, and the testosteronic side effect like norethindrone, the old one, norethindrone levonorgestrel, which is second generation progesterone, or tibolone, which we all know about in its role in HRT, desogestrel, the type 3 progesterone, and drospirenone, Dynoges, the newer progesterone. So these all are testosterone related, which are usually used in oral contraceptive pills and that can have the side effect of androgens. So definitely in HRT, you would prefer this compared to this, as well as recently the evidence emerging that micronized progesterone is safer in endometrial protection, and that's why nowadays in UK, micronized progesterone is quite commonly used for progesterone arm of HRT. So if we talk about progesterone regime in HRT, it can be given in two ways. Either it can be given every day, then it is called continuous combined HRT, or it will be given in the second half of cycle, then it is called sequential HRT. So it is the effect of progesterone is always time and dose dependent, and it has to be given at least for 12 to 14 days each month to protect the endometrium. So in sequential, when you give it for second half of cycle, they will have a withdrawal bleed every month. So it is like having bleeding every month, like period bleeding. And usually it is given for the perimenopausal women, the sequential one, so that because their endometrium is active, if you try to suppress that endometrium, you can't. They will have irregular bleeding. So you allow them to bleed every month so that they will not have irrational, irregular bleeding, and that will improve their quality of life. Now, once they attain menopause, after 1 year of attaining menopause, that means 2 years of amenorrhea, you will start them on continuous combined HRT. Why? Because now the endometrium is no more active, the endometrium is no more reacting, so there is no hormone. So, in such situation, if you give them continuous HRT, they will not bleed in between. The endometrium is not going to be overactive and bleeding. So you can avoid the unscheduled bleeding. But still, with continuous combined HRT, it takes 6 months for the body to settle with the hormones. And sometimes you have to try different combination because whatever amount of estrogen you are giving, you have to give the similar equivalent amount of progesterone to balance it. So if we talk about how much progesterone will balance an estrogen, 1 milligram of estradiol will be getting balanced by 100 milligram of progesterone. So that's what you have to keep in mind. There's in British Menopause Society guideline, there is the equivalent dosing of different type and route of estrogen with the progesterone, which is important. When somebody is using HRT and if they are having unscheduled bleeding, then you have to balance it. You have to increase the dose of progesterone to avoid the unscheduled bleeding. You never increase estrogen dose. You increase the progesterone dose to balance it because the beneficial effect of HRT is by estrogen. You don't want to give extra estrogen than what is needed to control a symptom. So you'll keep the estrogen static and you will try to increase the progesterone or change the type of progesterone or change the route of progesterone to avoid these unscheduled bleeding and balance it well. That's an important aspect. Now, if we talk about doses, if we are giving it sequential, it will require higher doses compared to when we give it in continuous, which will require either half or lesser doses. Progesterone can be given in different routes. It can be given orally, transdermally, vaginally, or it can be given in the form of Mirena, which is intrauterine device. And in this both regime, if we give them continuous combined HRT, that has a better protection for endometrial cancer compared to sequential. So we discussed about two types of regime, continuous and sequential. Continuous is suitable only for women who are more than 1 year postmenopausal or 2 years without period, same thing, or who has removed their ovaries, so there is no more hormones. Continuous will provide better endometrial protection, but it will be having the disadvantage of having the unscheduled bleeding in the first 6 months. That's why you evaluate after 6 months. When somebody is on continuous combined, you will evaluate them after 6 months by ultrasound to look for the thickness. And if they come with unscheduled bleeding, still ongoing after 6 months, and scan shows that the lining thickness is 4 millimeter or more, then you will do the hysteroscopy biopsy for them. So the recent evidence discuss about the risk of reduction of endometrial cancer and hyperplasia with progesterone. So they have evaluated, there are very many short-term and long-term trials which have evaluated the different route type and dose of progesterone, uh, comparing the protective effect on the hyperplasia and cancer. And all the studies have concluded and supported by the Cochrane review that whatever uh, progesterone type you use, it's always protective for cancer, and that there is no single case of cancer has been found if they are taking progesterone appropriately in appropriate doses. The PEPI trial also confirmed that reduction in the risk is with whatever progesterone you give, it will be there. There's no difference between micronized progesterone or medroxyprogesterone acetate. So, as I told, there is emerging evidence that micronized progesterone is also safe in terms of endometrial protection, and it's usually given orally, though it can be given vaginally as an off-license use for HRT. Now, no cases of, as I mentioned, no cases of endometrial cancer were reported in any of the group if they were taking both things in combination in equivalent doses. And micronized progesterone is also highly effective. Recently, the replenish study is also comparing the different ratio, and they found it's promising that whatever route and type you give, it is going to be protective. So when you're giving progesterone, how you will decide what route to choose, what doses to choose. As I mentioned, for doses, you have to compare it and proportionate to estrogen doses, you have to give that. In terms of route, you have to take in consideration the women's preference, the risk factors. What's her risk factor? What she prefers? There will be some side effects. So, what side effect would be tolerable for her? If they are getting troubled by the side effect, you can always give them the option of using it either vaginally, which is an off-license use of micronized progesterone, or they can have Mirena, which is near to the endometrium, give more doses to the endometrium and avoid the systemic side effect. It's very important to take in consideration the women preference to have a good compliance and to avoid the detrimental effect of estrogen on endometrial lining, because if they will not take progesterone due to side effect, then they are exposed at the risk of hyperplasia and cancer. What are the type of HRT? So in commercially available preparation, most of the time it is oral route is the most common method of administration, and in commercial preparation, synthetic progesterone would be the most common one to be used. Now we discussed that synthetic progesterone has two types. One is progesterone derivative and one is testosterone derivative. So testosterone derivatives are more used in oral contraceptive pills, and progesterone derivatives are more commonly used in HRT. So medroxyprogesterone acetate and dydrogesterone are commonly used, and now micronized progesterone is commonly used in HRT as an oral preparation. Now, micronized progesterone, when you give it sequentially, it will be requiring in a higher dose, as we discussed, while when you give it daily as a continuous, then it will be requiring in a lower dose. So, when you're using sequentially, 200 milligram per day, and when you're using continuously, 100 milligram per day is what is required. Whatever way you use, either orally or vaginally, the protection on the endometrium is same as we discussed. And the doses for vaginal route would be same as oral route. So there are different routes of administration, but it provides the protection in every route. Only it's about the balancing the side effect, and if the woman is uncomfortable with oral side effect, then you can always offer them the vaginal or Mirena. So these are the various HRT preparation. If you see progesterone only preparation, oral micronized progesterone, medroxyprogesterone acetate, or we can give intrauterine Mirena, or femostan, which is having dydrogesterone. Dydrogesterone is quite good safety profile, and it is protective for VTs, less side effect, more towards natural. So dydrogesterone is a good HRT progesterone. So femostan is that preparation, and then the norethisterone. These are the testosterone derivatives. So Novofem, Kilovens, Kilofem. Overall, Sequi and Conti, the name itself suggests Sequi is sequential and Conti is continuous patches. So these all have norethisterone. What are the side effects of progesterone? Yes, progesterone do have some side effect. That's why we are talking about progesterone so much, because it affects the compliance and it's important part of HRT. It might be mild, but in some cases it might be debilitating, especially for the women who already have pre-existing mood disorder, who had PMS, who had postnatal depression, who are already suffering with their unstable mood. Then they will be very uncomfortable with additional mood disorder of progesterone use. So most common side effect are mood disturbances and fluid retention, and androgenic side effect because of testosterone derivative, but they are less frequent. These all side effects are dose dependent and vary with the different progesterones. So micronized progesterone is associated with fewer and milder side effects. That's why it is preferred over the synthetic progesterone nowadays. Now sometimes we can some sorry sometimes we can negotiate in terms of side effect. If they are too much uncomfortable, we can tell them to reduce the doses, reduce the duration to 7 to 10 days. But again, we have to alert them, then the protection of the endometrium will be less, and we will be keeping a low threshold to evaluate them if they will have any regular bleeding, because there will be a small increased risk compared to if they use inappropriate doses and timing regarding the cancer. And the other option you can always offer is, as we mentioned, that they can have it either in a combined patch transdermally or intrauterine system. What we do with unscheduled bleeding on HRT? Very, very important, very, very common topic asked in exam. So it's very common in the first 3 months of treatment. If you give sequential for 2 cycles, you don't do anything. If you give combined for 6 months, you will wait and watch till it settles. But if they are having irregular bleeding, after 4 months, you will try to change the doses, route of progesterone, try to adjust it so that their bleeding pattern settle. If not, then after 6 months, you will evaluate. The incidence of unscheduled bleeding decrease with time to a rate of 3 to 10% at 9 months, which is good. Gradually, the body will settle with it. Unscheduled bleeding is more common with continuous combined. As we told, it is suppressing the endometrium, not allowing it to bleed every month. So definitely it will sometime have breakthrough bleeding. So it's more common compared to sequential, where you are allowing monthly bleed. Transdermal progesterone and oral micronized progesterone give less protection to unscheduled bleeding compared to synthetic progesterone. That's why the HRT, most of the HRT have synthetic progesterone, because they have, though they will be having some side effect, but at the same time they are good in controlling the unscheduled bleeding. And unscheduled bleeding can be disturbing for the women in terms of they will get worried for the risk of cancer. So synthetic progesterone has better control on the unscheduled bleeding, but transdermal and oral micronized progesterone will be having better side effect profile. So sometimes it's all about achieving the balance between the benefit and the risk and side effect. This is very, very important chart. If anybody has unscheduled bleeding on HRT, continuous combined, you will alter the dose and route of progesterone. Try to balance with the dose of estrogen. If it doesn't settle in 6 month time, then you will do the ultrasound. If it is more than equal to 4 millimeter with continuous combined and more than equal to 7 millimeter with sequential, or you are unable to visualize entire cavity, or you are suspecting polyp, in such situation, you will do hysteroscopy and endometrial biopsy. Now, this is very commonly asked in exam, the criteria of endometrial thickness, as well as these criteria where you will offer them hysteroscopy and biopsy to rule out cancer. Am I clear about this? This is really, really important to remember. Great. So what you will do, now we talk about Mirana, it is so good, it is so local, it is so near endometrium. Then what you will do if somebody will have irregular bleeding on Mirana, like unscheduled bleeding on Mirana as a progesterone arm of HRT. Then again, as I mentioned, that synthetic progesterones are better in controlling bleeding. So if there is breakthrough bleeding on Mirana, you will give them some supplementary synthetic progesterone in terms of medroxyprogesterone acetate or dihydrogesterone for few weeks. So we discussed about different regime of progesterone, doses, route, how it is dose and time dependent for everything. They should at least have 12 to 14 days of progesterone after stopping the period. After 2 years, that means 1 year after menopause, they can directly start continuous combined. Or if they are using sequential and you want, if they have used it for 5 years or they have crossed the age of 54, where 80% of the women achieve menopause, you can convert them to continuous combined. Why you want to convert? You want to convert because continuous combined has better safety profile on cancer, and your purpose of giving progesterone is to protect the endometrium from cancer. So you always want to use the safest one. So continuous combined is a good one. That's why you are converting from sequential after a while to continuous combined. And then you keep a threshold for evaluation for unscheduled bleeding. You keep a threshold for evaluating them. by ultrasound and then doing the hysteroscopy endometrial biopsy. What is the long-term safety? We discussed that progesterone component of HRT can slight increase risk of breast cancer. The absolute risk is very small, the benefit is higher. And particularly if we compare it with the modifiable risk factor, it's more of the benefit rather than risk. It's dose dependent, duration dependent, and ceases completely after you stop the treatment. So, in all sense, we have to make the women understand what are the risks involved. But again, it still looks safer to use it with the small risk involved. There are no randomized control studies about Mirena effect on breast cancer. So still, if somebody get diagnosed with breast cancer, you will remove the Mirena because you're not sure about the safety profile. And anybody who is having the breast cancer, you can't give them systemic HRT. You can only give them vaginal estrogen if needed. Other than that, you will be giving non-hormonal preparation for the HRT. If you talk about cardiovascular diseases, again, estrogen has a protection because it gives good lipid profile, good lipoproteins, while progesterone alleviate that effect by increasing the abnormal, harmful lipoproteins, and that's why it also have the impact on cardioprotective effect of estrogen. But still, the studies are going on, and they say that there's more research required to confirm this and determine that which progesterone confer the greater beneficial effect on serious risk. So still the research are going on, but it also time dependent that if you start HRT within 60 years of age or within 10 years of menopause, the protective effect is significant. And especially in premature menopause, it's all benefits. So in premature menopause, you will always give HRT till the age of natural menopause, which is usually considered here average as 51 years. So you'll give them till that age because there is no effect, no increased risk of breast cancer for them. It's beneficial for cardiovascular health and bone health and mood, dementia, for everything. In premature menopause, you don't have to think anything because it's absolutely safe and there is no increased risk of anything. But in postmenopause, you have to see that the earlier you start, within 60 years of age, within 10 years of menopause, then the beneficial effect on cardiovascular is preserved. In terms of stroke, again, there is conflicting report, but they say that if somebody has high risk for stroke, it's better to start them on transdermal HRT because transdermal will alleviate the side effect, and its transdermal HRT is always safer for any risk factor like previous history of VT, previous diabetes. Uh, I mean, any systemic problem which you think that will HRT would be safe, you can always start them on transdermal HRT because transdermal HRT has quite good safety profile. So as I mentioned, if you start early, if you start within 10 years of menopause, it will be helpful. Estrogen alone has protection more compared to with progesterone, but if there is uterus, you have to give progesterone. High risk of stroke, you start the patches. VT. Now, VT risk, we all know that HRT has a VT risk. It's mainly for the estrogen component. So, with or without progesterone, there will be increased risk of VT, 2 to 4 fold rise in HRT users, and most of the time, the first year is the greatest risk. In terms of VT, if we talk, micronized progesterone, which is more near the natural progesterone, and dihydrogesterone, which is progesterone derivative, these two are the lowest risk compared to synthetic progesterone. So we discussed the benefit of synthetic progesterone on unscheduled bleeding, but micronized progesterone and dihydrogesterone are better in other aspects like VT risk, like more avoiding the side effect. So you have to find a balance. If there is significant history of VT, again, you will start with the transdermal patches. The type of progesterone doesn't matter. There is always an increased risk of VT because of estrogen. In dementia, again, there is mixed report. The evidence gives us no clear-cut guideline about how much it is beneficial for dementia. But in this talk, it has been clearly mentioned that it is useful for premature menopause, for surgical menopause women. The dementia or mental fog, Alzheimer's can be delayed by giving them HRT. So it's beneficial for anybody who has premature menopause, surgical menopause, or who has started HRT soon after the menopause, you can delay the mm, Alzheimer's development for the women, and it will be helpful for mental fog. So it's again, it's when you start the HRT, the earlier you start, the better outcome you get. So to conclude, unopposed estrogen is associated with risk of cancer. So you are giving the progesterone to prevent it, but you have to balance the side effect, women preference, different routes, different type. You have to balance the equivalent dose of estrogen. You have to evaluate unscheduled bleeding. You have to be, by changing the type and dose and route, you can always find a balance for the women. Micronized progesterone is more selective action on progesterone receptor. That's why nowadays it is used very commonly. And nowadays the emerging evidence confirmed that micronized progesterone is having the similar safety profile on endometrium. So that's why it is used here. In UK, the micronized progesterone is commonly used as a part of HRT, and the vaginal use of this is off license, but it can be used. That the name is utrogestan. Now, Mirena in preparation containing dydrogesterone has minimal side effect as we discussed earlier. So that will promote the treatment compliance for the women, because it's important to use progesterone when they are using estrogen. So that's all about the progesterone use in HRT, and you definitely get questions in exams. So it's important again to re-emphasize that the course is starting soon. So if you want to start your preparation in an organized manner, in a time-bound pattern, with your busy schedule, you can choose us. All the guidelines will be discussed. There will be questions, mocks. There will be uh, important topic will be discussed separately, so there's all help in your thorough preparation for the exam. Thank you for attending today. Bye, have a good day.